All right. So, okay, so this is the location. That's your numbers in terms of caseload you might be
Yes,
getting per
correct.
year. All right.
Correct.
Okay.
Correct.
And what is your research? Okay. Problem is, are you going to be observing? Okay.
So
Observation is fine, but do you have two groups, one group? What do you have?
sorry again.
Do you have two groups or one group? What do you actually have?
Okay, now
What's
actually
your
I'm doing this new technique. Then while comparing actually with historical data on the conventional method.
okay? So you do have you have a group of historical data where they're using a
Yes,
different technique, and then you're going to look at the current technique which is being used, right?
yes, correct.
Okay, so then I do have a question in regards to that historical technique. So is it that the historical method is still a way people are still using it? It's still in the guidelines and as an option, or what is the gold standard now? The new technique or
Now
the old?
actually the new now that actually the new technique has been actually used as a standard.
If the new technique is already set at CAT, the reason why I'm asking all these questions is not to make it difficult for you, but the panel will come up now and ask you if that's already the gold standard. Why are you testing something which is
Oh, I
which
mean,
is
sorry, I mean,
what is like the new thing you're trying to answer here? Like what is the novelty of you looking at the historical cohort? What are you trying to prove?
okay, so,
Yeah,
sorry. Let me rephrase.
yeah,
Because this technique actually is not the gold standard per se. It
yeah.
actually is our own local setting modified technique that
Okay.
actually we have seen actually improving in the outcomes.
Okay.
So actually, and then but we do not have any study about it actually. So that's why I'm actually
Okay, so you have there is an existing method in the guidelines and that's being done, but your center is practicing a
yes,
modified version of it, and you
yes,
want to see whether now you want to actually look at it and in terms of whether it actually has good outcomes, correct?
correct.
Okay, all right. Continue to your objective. What's your research objective?
Mm,
This is your problem statement.
yeah,
Where's your research objective, research question? Yeah,
hold on.
if you have it.
I have it.
Yeah.
This is my research question.
Okay, so does this bell technique of open, so you have lower rates. Okay, so that's your thing, lower rate. So you're looking at a
Yes.
rate, current malfunction, 30 days, then
Yeah.
the conventional technique.
Yeah.
Okay, so
So this is my research objective.
okay, to compare the rate
Yeah.
at 30 days post-op at 3 months. So
Yes.
that's all your secondary, okay? And then
Yes,
and
correct.
all of that. All right. So actually your main outcome measure then is the rate of catheter
Yeah,
malfunction
at
in
the
30
30 days.
days. Okay. Now when it comes to that, in your historical cohort, or
Yep.
is there reference papers on what the rate was for before this new technique? Do you have
I mean
numbers? Like
the
what is the rate?
conventional, is it?
Yeah, conventional.
So actually the conventional, let's say this is actually there was actually a meta-analysis
Yeah.
actually using the conventional method. So these are
Okay.
actually the migration and infection rate. Actually compared to our old data, historical data, actually the almost is actually similar to the meta-analysis.
Similar. Okay. Yeah. So okay. So the meta analysis now, when you say migration rate, it's because it's. Do you mean the malfunction? Is that what you mean? What do you mean? What
This
is the
migration rate is just purely the migration because my catheter malfunction is including all the catheter displacement and non-catheter displacement.
so they no you don't have any numbers for the historical of what the percentage would be when it is yeah, you don't have the percentage in terms of 30 days malfunction on like what the known numbers are.
Yes, but
No one has ever reported it.
I do have one paper which
Yeah.
actually they have actually studied regarding some modified technique which is similar to mine. which is this first Chengshan
No,
study.
so not for the modified, because you're also going to be doing modified, but you're doing a different modified than this paper in 2015, right? I need a reference of this one, a paper showing the 30-day malfunction for the conventional technique. Like what is the known rate when someone previously reported it? What is a known rate?
Okay, I see. Because so far all the literature about the conventional technique, they actually have only talking about the migration, the infection, and leakage rate. They don't have the catheter malfunction per se.
Okay, because that's going to make it difficult, right? Because you want to look at that 30-day malfunction.
Okay.
What is the conventional technique called?
The conventional technique is just a normal standard of insertion technique actually.
Thank you.
So insertion of catheter, you mean?
Yeah, it's just a Tankoff insertion.
Yeah.
They don't have a specific name for it actually. Yeah. Hello, can you hear me?
Yeah, I can hear you. I'm just trying to see myself. I'm trying to look for a percentage. I mean, the number which you have there, migration is very different from your 30-day. It's a different outcome. If you're looking at 30 days compared to migration, you see, so you can't use that percentage which you have in that table as your reference number. You really need one which actually shows the failure. I mean, the 30-day malfunction rate, especially for the conventional technique, considering that I'm quite surprised no one has reported it before.
Yes.
So yeah. So how are you going to get a percent? You need one reference at least, either for the new method, what the number is, and then you can say conventional would be worse by 20%, or the other way around, conventional is worse by 30%, or the other way around, where the conventional, you know the number, and then you say that you'll see an improvement by 30% in the, if you go with the Bell,
Actually,
with the new.
let me just take back the first actually this reference I saw. They actually did their outcome actually did look at the catheter malfunction. Because they are
Which reference is this? Which paper?
this
That.
chunks. Yeah,
So
correct.
they looked at it for conventional or for your technique?
Because it's a RCT. They are doing RCT comparing actually their modified technique and also the traditional.
So then we can look at their conventional technique number, right?
Yes, correct.
Yeah. So can you try and get that rate, that percentage for me? Yeah.
The traditional method is 19.5%.
Okay, so 90.5. So do you remember I showed, and now my question is, your modified technique, you think it's going to be as good as theirs, 4.2, or you think it's going to be equally as good as 19.5, or what do you think the percentage is going to be?
My percentage, I will expect actually this is a superior study. That means my modified technique will be better than the traditional method.
Okay, better by what? At least 20% better, or the reason why I'm asking that is, do you remember, I'm not sure whether you came for my talk last week, but there is a way of putting in two proportions, and I think that's the way you can actually calculate your sample size. Let me get hold of that link, then you can share it on your side.
Okay.
But of course, you're not doing an RCT.
Actually, for my center.
Yes.
Yeah, for my center, don't have actually a proper audit regarding the risk reduction actually.
Yeah, but that's why you're doing a study, aren't you? Because you want to see what. Okay, so you can try. you could try something like this. What is your proportion? Let me try this. Wow. Okay. Okay, you could try this, but maybe this is not the best link, but I'm sending something in the Zoom chat. This is for two proportions. So what I would suggest is you use this as your reference paper, saying previously a modified technique was able to bring it down to 44.2, and the conventional technique was 19.5. So you already got a reference for one of it, right? So the 19.5 is fixed. So you already know one proportion is going to be about 19.5%. Now is finding a reference for your technique, which it doesn't exist, fine. But do you want to, if you want to reduce the 19.5% by 30% reduction, that will make it, let me calculate that. So I need a calculator, sorry. 30% of 19. Will then give you, so the reason why I'm saying 30% reduction is normally that's the acceptable reduction when you are trying to at least get a superior, that you believe one is going to be superior than the other. Okay, if you want to prove both are equally as good, then it's 19.5 and 19.5, but your sample numbers will be very high. Okay, yeah. And so that's not what you want to do. You want to show at least one, and based on this other paper, when they had a modified version, it was at least better, right? So, okay, 5.85. So 30% reduction will mean that your technique should at least be 5.85% compared to 19.5. Do you want to go with that way of explaining, that you wanted to see at least a 30% reduction on malfunctioning of and that 30% is also a reference that that's what you want to see as an improvement in any technique.
So can we actually, sorry,
yeah, how I did that was basically I'm putting the formula. I mean, I'm putting the maths. It's not even a formula, it's maths. So you had 19.5% is the conventional technique. Okay, 19.5. Okay, so then I did 30% times 30, so 0.3 times 19.5, and that should have given you 5.85, but you can check with a calculator yourself. So that's why I went with 5.85, because I want to at least see a 30% improvement, reduce that 19.5 by 30% is 5. Actually, no, then it will be 19.5 minus 5.85. So that should be your absolute number. Yeah. Okay. Sorry, there's one more step. 19.5 minus 5. So 5 minus 5.85 is 13. So at least you want to see it reduce it by this. Unless you want to reduce it by 50%, then it will go, yeah.
Actually, I did some sample size calculation myself.
Okay, do you want to show me what you have to see whether it's justified, like whether it's correct? Yeah.
Because I actually took the literature numbers, I mean the 4.2% actually
as your reference. But the thing is that 4.2 is for their modified technique, not your modified technique. So yes, you can say you want to follow theirs and believe your modified technique is equally as good. But you know what will happen there? They'll say, then why don't you just use their modified technique? Why you want to make your own? So then it will hit back to the novelty. They will say, what's the point of doing so many different modified techniques? But you can easily justify saying that modified technique is applicable for their setting, but may not be something which we can do in our local setting. Okay, you understand? And hence we want to see whether our modified technique is equally as good as their modified technique. then they'll say, don't you want to then compare? They said that we can't practice here, hence we're practicing our modified technique. You understand? That's how you answer the question. I hope
Oh,
I'm making sense. They'll
okay.
ask you why you're going with 4.2 when that's not the technique you're going to be using. But
Okay.
that's fine. Okay, you can show me what you ended up getting.
So this one actually is I using a G power now. So actually I create this contingency table and I
Yeah,
get proportion. So in
yeah,
the end, actually study sample size by G power with a 0.8 the power. So will be 134. So with a 20% dropout rate will be 168 84 per hour.
yeah, 84 per arm. That actually sounds reasonable to me. But are you sure this is with 40? You said you put in 4.2, is it?
Right.
Okay, let me just see. 68. Okay, you also had your dropout rate. That's why. Okay. Yeah, that's correct. Actually, that's what I'm getting as well on that link which I sent. I'm getting 70, and that's not including the dropout rate of 20%. So that will bring it up to 84. Correct. Yeah. So I think you can go with this method. You know what your reference paper is, right? For this,
I
your
know.
reference paper is that paper you showed me, that
Yeah.
2015 paper. And I believe the numbers which you're showing is correct. Now, my next question is, are you able to get these numbers though? For
So far, actually, I have actually one question because I'm comparing the historical data, right? So let's say I have a discrepancy in numbers. That means my ratio is 2 to 1 because the conventional method was actually the
yeah.
numbers larger. So is there any problem with that?
So but when you're collecting, are you going to be able to get 84 of the historical
Actually,
and
that
84 of this? Are you going to be able to first that answer that bit first? Whether 84, are you going to be able to get 84 of the historical cohort, the conventional, and 84 of the new technique? If
yes.
you can, then stick with 1 to 1. If
Okay.
you cannot, then you go 2 to 1, if
Okay.
that makes sense.
Sure.
Yeah.
All
If
right.
you can get enough numbers, then keep it to a 1 to 1 ratio. If
Sure.
you cannot, then you modify it that you get 2 to 1. So your whichever you know you're going to get less numbers will be the one where at least you get one representative, if that
Okay.
makes sense.
Okay. Sure.
Yeah.
Understood.
Okay.
Yep.
And you can justify that because one of it is less in numbers because it doesn't have so then you went for a 2 to 1 ratio. Okay. Yeah. I think your numbers are correct and you're using the right you see earlier if you use the migration, you know how you're showing me the migration rate and all of that, leak, all of that, you can't use those numbers to calculate because your main outcome is this. It's actually the 30-day failure. Right? I'm saying failure, but what I mean is the malfunction. So you need numbers to match that malfunction numbers. Okay. So this is correct because now you showed me your reference paper is for that. So stick with this. I think if you're going to present this, they will not question you. Just put your references correctly. That's
Okay.
all.
All
Yeah.
right.
Okay.
All right. Thank you, bro.
Welcome. Um, I think maybe someone else wanted to clarify whether their sample size calculation was correct. Do you have any other question in regards to
So
your
far,
sample
it's
size?
just that now you were mentioning about the question when they say their technique is not exactly as mine, but why do I use a 4.2%, right?
Yeah,
Yeah, so if let's say because it's a local practice that we already standardize this technique that we use, could it be
yeah.
just
Yeah, that you can say that and you can explain why. The other thing you need to find is why that modified technique is not something which you can try here. So there's two things to explain. One is why your modified technique. Obviously that you have already got some sort of efficacy, meaning like safety, all of those things have been done, and that's why it's being practiced in the in the hospital in Johor. Okay. The other thing is why that modified technique in that paper, the one, where was that done? Actually, the 2015 study, was it in Malaysia as well or somewhere else?
No, that was only actually the most of the paper is only in China. So no.
Yeah, so that's also the other thing which we say, like that technique maybe is something which, there are a lot of things can be factors, right? Not just location. It could also be that you might need to get them, they might have used some equipments which we don't have here. I'm not really sure how the technique works, so sorry about, but but I believe many reasons the technique, it's not just the training or the skill of the surgeon. It could also be things like whether you can get those materials, whether you can get those machines, whether that technique needs special training, which means you have to send someone over there to learn how to do it and come back and do it here. There are a lot of factors. So, and while this technique which you are testing has already been trained for that's what I'm saying, local, for local locally trained, locally devised. Hence, it's something which would be, and it shows that there is good outcomes, but it's just not observational. It's just kind of like uh, opinion based judgments saying that it's good. Now I want to do the study to show that it is actually good in by quantifying it with with the objectives which I'm presenting, which is the obviously the main is the to show that it reduces in malfunction of the catheter within 30 days is good. And then a long-term look at it in terms of 3 months that it still stays. And hence, that's why I'm doing the study, because we need some quantity, not just quality kind of data saying, yes, surgeon said good, patient is happy, but some things which are measurable. And that's why I'm doing the study. So that's your new data, your novelty. Okay. Am I making sense on what I'm trying to say? Like what is new about your thing is those things. And that's why you're not using that old tech, that not old technique, I mean, why you're not using the old technique, you want to, the conventional technique, but also why you're not trying to use the technique done in China here, because it, to do that, then there are other factors which are involved. Why? So I want to show, and which is common, because you do know that even with scoring systems, there are many scoring systems out there for different things, from stone to quality of life and this, right? Doesn't mean you use everything which is done overseas here. You might need to validate for the population here. You might need to might have to modify that scoring system so that it is to local settings. So the same reason why you're using your modified technique, which you're using compared to the modified technique done in China in 2015. Yeah. Okay.
Right. Thank you, Prof.
Yeah. Okay. So I think you wanted to present something.
Yes, Prof. Allow me to share my screen.
Yeah.
Okay. So regarding my study,
Yeah.
just a minute, can I control it? So this is the title of my study, Utility of Total Omentectomy on Gastric CA with or without neoadjuvant chemo. And my problem statement is, it is unknown whether total omentectomy post-neoadjuvant for gastric cancer is necessary. So the standard of care now is total omentectomy is necessary. Okay, so it is a retrospective study. So I will compare all patients with gastric cancer as it will basically two arms, whether they underwent neoadjuvant or no neoadjuvant, but both with curative intent. So then I will do a multivariate analysis. So the things, my outcome of the study is I want to see what is the incidence of omental mets, and post-neoadjuvant, does the incidence of omental mets reduce? So actually, well, for my sample size calculation, I used the incidence of gastric cancer in Malaysia. So actually the questions I want to, the sample size I got is of 99. The questions I want to ask is, my supervisor is worried that because we are using two arms in my study, although all patients of gastric cancer, but we divided into patients with chemotherapy and not chemotherapy. Is it okay that we take 99 as for both and divide to 50 in both arms?
Okay, so before I answer that question, if you have two arms, then you probably will need 99 per group. Okay.
99 per group. Okay.
Yeah, 99 per group. But having said that, because you did say your analysis plan is going to be multivariate, can you explain that a little bit more to me? How are you going to analyze this? Are you using a logistic regression? Are you using you're comparing
Yes.
just in terms of mean and this? If you're using logistic regression, what are all your factors which you're collecting? Because if it's logistic, do you remember you didn't come for the talk last week, right? You mentioned that. So for logic regression, you actually can just use that reference of every factor which you're going to put into the multivariate model for your regression model, comparing those two things, who went for, obviously two groups is the ones which went for neoadjuvant and the ones who didn't. You actually just need to do 10, you need a minimum of 10 patients per factor. So then which comes down to you listing all the factors you're going to look at, and then timesing, say if you got 10 factors, you times it by 10, then you will need 100. Okay? If you have 20 factors, then you need 200. Okay?
Okay.
The reference paper, I think I'll share that screen later to show you which reference I'm talking about. But that is what actually you should be using for your sample size calculation. You don't need to go with the proportion, because yours, one, you're using all retrospective data. Two, you're actually going to do a multivariate analysis, using logistic regression, looking at what factors are contributing, what factors are associated with basically the two different arms, what actually drives on poorer outcomes. So that is the sample size calculation you should be using.
Okay.
Correct me. Can you maybe show me the slide of your main outcome, your primary outcome? That means your primary objective, secondary objective.
Yeah.
Okay, to examine the correlation. Okay. Okay, yeah, so you'll be doing okay, so not logic regression, because you're looking at recurrence and matter, you'll be doing the hazards ratio, which is the same. So for hazards ratio or logic regression, when you're going to use regression model, you will actually use this reference paper. Let me see if I actually have the slides on my laptop. If I don't, I might disturb Nadia to share my slides. You have, Nadia, my slides from last time? From last week? Actually, I do have mine. Let me see if I have it here. Yeah, I do have my slides.
Okay.
Okay, so let me share screen.
Okay, sure. I'll stop sharing.
It probably will work out to the same around 9, well, not 99, 100 if you have 10 factors, but you need to sit and be very clear on the number of factors you're going to look at. So let me just share the screen. Okay, so I'm just going to go from the beginning because it's just easier for me. So it's not RCT. You are actually dealing with, this is just me explaining what I need to do sample size. Okay, you don't need any of this. RCT, it's towards the end. Okay. Yes, yours is this predictive models, right? Because you're looking at what are the factors in your two groups. So you actually need one for every variable. You need 10 events, which means 10 subjects, which is 10 people. And so you need to figure out how many factors you are looking at. That means your T stage, your N, your T, your N, your M, and then your other things like recurrence, all of those factors, each of it should be one, right? And then each of it, so like the 4 which I named, already 40, you need 40, okay? then keep adding other variables, even as simple as age, race, all of those things, if you think those are going to be put into your hazard ratio model at the end. Okay.
Okay, so
Yeah.
actually,
So I wouldn't know. Do you have a pro forma? Do you already have like a pro forma? When I say pro forma means your data, your capture sheet, like what are the information you're going to be extracting from the EMR system and collecting information, so that it could be your demographics will come on the top, obviously, which is
yes.
just general, right? Then the
Yeah.
next bit is your pathology, radiology results. Then will be the date of recurrence and all of that, all the different dates, follow-up dates, all of those dates will be captured, right? And then anything else, other factors. So each of it will end up being a factor. So if the way I'm naming it, it sounds like you might even need uh 15 50, it sounds like that you might have 15 factors or even 20 factors. So you really need to have that pro forma ready. You'll need it also to submit part of your ethics. So yeah, okay. So work that out, and then you basically just reference these two papers and say you went with the rule of thumb that every variable needed a minimum of 10. And so because you had this many variables, you then times it by 10, and I need 200 or I need 150. That's it. And then say this is my reference. Okay. And you can see that that is actually the rule. That's actually so this is what I mean. So you're going with this method. So can you see when it's Cox regression or logical regression, you actually go with that reference paper, which is
Okay.
what I presented just now.
I
Okay.
see.
Yeah. So not proportions.
Okay, because it's very different from the statistician I consulted. I can't remember
I mean, it works out to similar. I mean, 99 works out to about 100, but it's actually not the way you should calculate. So that there are a few things which you need to consider when you calculate. One is the first thing you look at is what your main outcome is going to be. But when you are doing something like yours, you also need to look at how you're going to analyze the data. And so because you're going to analyze the data, looking at all of these factors and looking at multivariate and hazards and so forth, I would actually not calculate it based on the main outcome. I'll calculate it based on how I'm going to analyze the data. Yeah.
Okay.
Okay.
Yeah. Okay. Thank you so much, Prof.
Yeah. So later, I think the slide is my talk last week was recorded, but I was supposed to circulate these slides, but I was going to do it after today. I was going to send it to Nadia. You have my slides already, right?
Yes,
Nadia, are you
Prof.
there?
Yes,
You
yes,
have
I
my
have.
slides. You can save it as a PDF and send it to
Okay.
everyone. Yeah.
Yep,
Then
okay.
they can have a look, and then yeah. Okay. Otherwise the recording, I think it's not on our website because I think Fazli said something's wrong on our website, right?
Yeah,
Our
I think
YouTube.
yeah, I already gave it to him.
Yeah.
I'm just waiting for him to upload it lah.
Okay. So then when that's uploaded, then that YouTube link also can be shared to people.
Yep.
The others who are here, do you have any questions?
All good.
Okay. All right. Otherwise, if there's no other questions, then I might end the session early. How many of y'all who are here right now came to the talk last week? I know you said she wasn't able to attend, but it is recorded. Anybody else? I think Jasmine, you joined last week as well, didn't you? Philip or Hangisa doesn't need the talk, but yeah. Anybody else who you missed last week as well? Oh, you missed last week. Okay. All right. So the reason why I'm asking that is I'm not going to present the whole thing, but I might present parts of it today just so that the ones who didn't attend can listen to parts of it. I'm not going to be doing a full presentation though. Okay, so I'll present the slides just so that these you guys can see what was presented. Yeah, I'll do that now. But Nadia, I don't think you need to record. Oh, you are recording as well, right? The session? Yeah. Right. We'll go from the start, but I will skip some slides when I feel it's not necessary. Okay. All right. So basically, the talk which I gave was to kind of explain why sample size calculation is needed, why it's important, how to actually be very clear on which factors to select. I think a bit of it I've been already covering with the one-to-one discussions I'm having with each of y'all, but I will explain further on that. And then basically like explain why sample size is needed for all your studies, okay? Now, it all starts with your research question. And then as I've already mentioned, you need to be clear what your main outcome is. That means your primary objective and what is your main variable going to be. And if it's not one main variable, as per like the discussion I was having just now, where there's more than one variable, you might, that's fine as well, but then there is a calculation for it, which I was showing kind of. I'll come back to it again now. And then you kind of need to then know what your sample data is and the statistical test you're going to use at the end. All of that is needed in order for you to calculate the sample size correctly, okay? And why you need to do this is because you want to kind of debunk the null hypothesis, which is saying that there's no difference, to say you can either accept it or reject it, okay? So then because sometimes p-value, something can be statistically significant, does not mean it's always clinically significant. And so first you need to prove that it's statistically significant, after which you need to then make sure that it's also clinically relevant. Okay, so and hence sample size calculation is needed because you can have two kinds of errors which come in in stats, which is the type 1 error where when there is a false positive, when something is not actually there, but you say it's there is a difference, but actually there's no difference. Okay, you want to reduce that error. And you also want to reduce you ruling out something when actually false negative is when you say that it's not present, but actually it's present. So to reduce this two type 1 and type 2 error is why you need enough sample size, because you want to actually say your study is powered for a bigger population, okay? And what is power? Power basically is able to debunk the errors which may turn up, okay? So that's why the general rule of thumb is obviously if you do a census, you collect everybody in the country, you don't need to do sample size calculation because you're representing the whole population. But can you do that? You don't have the time, you don't have the manpower, you don't have the resources, and not every it's not applicable to be doing that unless it's a population-based study or census or a nationwide driven study, while you are doing something which is just at your hospital setting or maximum 2 hospitals. So you need to kind of justify your sample collected is representing the bigger population which is out there, not just the country, but worldwide maybe as well. Okay, so a sample basically is small representative of the bigger population. So as I've already brought up these points, obviously I'm speaking ahead of my slides, but basically you don't have the resources and manpower to be collecting everyone. So you work with the sampling frame. Sampling frame in this case is a hospital. Sometimes if you do community studies, will be the outreach program would be your sample frame. Okay, some bits of this I think Hamiza will know because these are similar terms used in qualitative studies as well. Okay, so that's why you need a sample. So I'm not going to be explaining these slides. So you first need to decide your target population, like your examples which you've been giving. You have your group, which your target population will be the ones having getting a catheter put in and so forth for the study, which I think just now I was trying to check that the sample size calculation is correct or not. And in other cases, in terms of the second study, your sample population, your targeted population is obviously people who are going to have recurrence and not are the people who are going to go on the 2 different therapies, right? So people are getting the therapy, okay? So hence you need to be very clear. Your inclusion and exclusion criteria is very important. And that's why that is also something which we check when you present. So be very clear who you're including in your study, who you're excluding in your study. Okay, and then that will bring to, all of that will bring to you having to calculate your sample size and making sure that your sample size is the right numbers. Okay, so this is kind of giving you that whole, normally census, you take everybody, but that's not what you can do. You study population, the people with the disease or the people who are going for a certain treatment, and you are just kind of taking 1 center or 2 centers. And so then you're not actually taking everyone there. You got your inclusion and exclusion criteria, and then to be strict enough to be so that it is comparable, and that is your sample. So, and your sample is what you are trying to calculate in terms of to justify that your sample size calculations and to justify that your sample is correct. Okay, so this is just to give you a picture of it. So you're not taking everyone, but you're trying to represent everyone. As I said, census is when you collect everybody. Okay, which you understand because that happens, and the government sometimes does census, right? And they report numbers. Okay, I'm not going to go with this whole probability sampling and non-probability, but this is just basically saying that you just randomly collect samples or you systematically collect samples is basically what these 2 terms are, okay? And so this is what I was having the discussion with each of y'all. I mean, this now the 2 people is I was asking what was the primary outcome. Primary outcome is your primary objective. What is the main measure thing you're trying to compare? But how many groups you have, whether you have 1 group or 2 groups. I think we were having the discussion earlier as well. And you design, whether it's retrospective, prospective, observational, all of those things. And whether you're trying to prove something to be better or not. The first example where I was having the discussion was that they are trying to prove that obviously to the conventional method, that the new modified method is superior, okay? But not, you don't need, those are normally, these things need to be there when you're doing comparing 2 arms. Now, obviously you don't need to show whether one is superior and everything when you are trying to prove, you try to look at factors, okay? So then what is your output going to be? Is it percentages, mean, median, or is it going to be logistic regression? So this is this comes to the what we were discussing just before I started doing the presentation, what kind of data analysis you're going to use. So not just, in your case, it'll be hazard ratio since you're looking at recurrence and so forth, but it's still the same kind of model. So that comes to, you still will be dealing with p-value, but you'll also have your confidence interval. But sometimes you might not deal with p-value when it's something like rare diseases and all of that. You might go with effect size rather than p-value. There are some studies where they do both. They will report the p-value and the effect size. Okay, sorry, I went back into the previous slide. Okay. So effect size is basically like what, so this, the reason why sometimes effect size comes in because they say p-value is most for statisticians, while when you want to see something which is clinically relevant or relevant in terms of having effect, you might want to represent it as in terms of how much better it is, whether it has 10% improvement, 20% improvement, or 50% improvement. Okay, so effect size comes in, but they don't really, we still stick with p-value, and that's why you do the power calculation instead. But effect size is useful for like pilot studies, for rare diseases, those kind of things. I'm not sure whether anyone's doing that where you're dealing with just a very small target population, but there are sometimes where the statistician might calculate the sample size based on effect rather than p-value, okay? So this, I'm not going to go through this because I don't think anyone's doing RCTs, but this is a old school formula which was created a long time ago by a statistician when you are looking at RCTs and looking at just comparing 2 groups, and whether it's t-test or chi-square. And it's either that you actually have the mean value and standard deviation value, and then it's calculated. And based off that, using the formula which they have, it will then come up with a standardized difference. And that standardized difference, if you draw, and this is your power, 80% power or 90% power, this is 80% power, this is 90% power. When you draw a line across, it will tell you what the total numbers are needed. And based off that, total numbers needed, and it's 160, and each group will need 80. So this can be done for RCTs. This formula is specifically for RCTs, so it cannot be even for observational studies comparing two groups. This has to be for some, I mean, it can be for observational studies, but it has to be an RCT model. It cannot be something where you are not fixing your grouping, okay? Cannot be for retrospective either. Now, proportions, so like if there's a prevalence in what you expect to find and compared to what it is existing, so then the formula, this is when you're dealing with percentages. The other formula was when you're dealing with mean and standard deviation value. And again, these are again for RCTs, but then you work out the formula, you come up with the final standardized difference using that formula above. What it is, this one is 5.8. And again, you draw a line, you say 80% power, and you see what numbers are needed, and then it says you need about 43. Keep in mind, this one is saying 43, but it's not including 20% dropout rate though. So you might need to add another 20% to this 43 to see your absolute numbers needed for an RCT design. Okay, and this is just a quick formula. This is an online website which does the same thing as that graph which I'm showing you, and for proportions. Now, the reason why this one and what's useful more on this website is that in case you did not, nowadays we make sure you calculate and make sure it's powered, but there was a time where people weren't calculating and you might have just collected and you're not sure whether it's powered or not. So you can actually put in what your actual results are and work out what the power is. And you can see the power is at 75%, so it's not 80% power. So it's not powered yet to represent the whole population. So it's actually doable to post-check your sample size, but we do not recommend that anymore because, as you know, when you come to the evaluating panel, they check that you are collecting sample size and that the sample size is powered at 80 at least, okay? But this was things which I used to give to seniors in case they have collected already and they have no choice but to say that they're not powered and to show at least what power they're sitting at in terms of what they did collect in terms of sample size, okay? Now, there are a lot of references out there. Again, I think I will send this reference paper to Nadia. Nadia, did I send you yet the reference papers, or I only sent you
not yet, Prof.
Okay, I'll send you these papers also. So there are
okay.
papers which are out there which explain when it comes to RCT, when something is superior, when something is equally as good, and so forth, and terminology so you can read. And then the sample size, the reason why this is important is because the sample size calculation for a non-inferior or an equivalent study is different from when you're calculating for an RCT for a superior study, which I was showing you this now. You can't use that. You will have to use a different formula as per this reference paper, okay? You may put in the same numbers, but you have to use the formula from this paper, okay? I'm not going to go through the step-by-step math, so anything like that. I'm giving this whole talk is to give you guidance on knowing first how to start and how to speak to the statistician. You can actually let the statistician know. So they need to know whether your study is superior or not, whether it's inferior, or you're trying to prove something that's equal and all of those things. And they can calculate for you accordingly using the online calculators which they have, which can be G-Power and a few other things which normally the CRC and CIC has. Okay, and even so you can just tell them. So which now brings to, if you're not dealing with RCTs, you're not dealing with comparing two arms and so forth, and you're actually just dealing with a whole retrospective study where you're collecting all factors and you want to prove something is better than the other, or what are the factors which may have a role in this, or hazard ratio or anything like that, then this is what I was presenting this now, that you actually go with the rule of this two reference paper, especially with Pedigree. It's already shown that based on their maths that you at least need a minimum of 10 per factor or per variable you're looking at. Okay, you can't use this though if you are doing observational study. Okay, this is for when you're doing a retrospective study or a prospective study, trying to collecting factors, and you're trying to do at the end some sort of regression model. Okay. Now, remember I mentioned effect size. So when you deal with pilot studies, a better way to justify. So this is a reference paper. If you say at the end you are doing a pilot study and you're not going to be dealing, there's already a reference papers which are out there saying that at least you need 30 per group. So if whether it's 2 groups or if you have 3 groups, so 30 per group. Some do say 12, but depending on your feasibility, that means like how many numbers you can actually collect, you can either go with 12 or 30, and you reference the paper according to these 2 papers and say that you're doing a pilot study, and based on my pilot study, I'm going to go with 12 because of this reason. You justify and say this is the rule of thumb which has been published by this authors. Okay, and that's why I'm going with 12 per arm or something like that. Or if your sample this is fixed. Okay, so you will then, so area under the curve, anything here we've put 0.725, but actually a good area under the curve should be at least 0.7 or more. The better is actually 0.800 or more. Okay, so you put that number and then you hypothesize what you think the value is going to be. Do you think it's 0.5? All of these are fixed already. Your ratio, like how many you're going to get in your negative, your pickup rates, is it 1, is it 2? Okay, but you can just fix it. This is all fixed, and it will pop up a number, what sample you need, how many cases you need, and what the total sample needed. So in this case, it's saying 57 based on the numbers which are keyed in here. And this is just for one test. But what happens, you're trying to prove 2 different scoring systems, okay? Like say you've got stone scoring system A, like you score, and the area under the curve, you have those numbers from a previous paper where they're looking at scoring system A compared to scoring system B. Then you do not use this because this is just for one. Then you will actually use the comparing to ROC curves. Okay, so then you kind of key in what the ROC curve value for scoring system 1 is compared to the ROC under the curve for 2. And then you kind of say what you think the correlation would be for your positive and negative, what you think the pickup rates should be that rule out for positive and this. You can use a reference. You'll then have a reference paper for this, reference paper for this. And this one, you kind of pick what you think the best scoring is, whether you want to equal and so forth. And it will then tell you what your total sample size is needed. Obviously here it's telling you need almost 400. Okay, so, but it's just an example where I've kind of put in the numbers and I've copied it across. Now, as you already know, some things are fixed. Things which are fixed is your type 1 and type 2 error. The things which you need to key in is basically what is in the input is what you key in. Okay, and this is where you need your reference paper. Then what it comes out with is based on what you key in here. So you need to have reference paper for these things. Okay, for these things. This one is fixed. You don't need to do anything with that. Okay, this is when you, if any one of you are doing studies with ROC curve and diagnostic tests and so forth. Okay, and then this is a summary of say if there's other kinds of methods which you're using in other studies. Cronbach alpha is normally used when you are dealing with validity, like when you want to validate a questionnaire. So yeah, so these are reference papers, but this is a starting point on knowing. So in summary, you need to know that you need to be first very clear what your main objective is, so that you know what your main outcome is. You need to know how many groups you're dealing with, and more towards, and it's actually very important from the beginning itself, you should know how you're going to analyze your data. Okay? All right. Thank you for listening to me. Stop sharing. All right. Any questions?
Good afternoon, Prof. Kanashiu here.
Yeah,
Actually, I have a question. So,
yeah, sure.
just for example, what's your take on universal sampling in the case of, let's say, for example, on my study, if let's say I'm gonna take all of my patients in my center, of course, if it's a universal sampling
You
in
can, I mean, because you are doing a retrospective study,
okay,
you can say that you're going with universal sampling, but the question there will be that are you actually going from the very first time you had a case? Because you could be only taking for 10 years, right? You're collecting just for 10 years or 5 years. Then it's not really universal sampling, because universal sampling is you have to take everybody from the time those kind of cases have been until now. So it's not going, you can say it, but it's better to actually justify with the other way, where the factors you're dealing with, rather than say universal sampling. You can actually say that, because a lot of retrospective studies are basically what you get is that's your numbers, but sometimes they might, when I say they, towards the end, the people who are asking you to justify or explain your study, they will ask you, okay, fine, universal sampling, but why, can you explain why your numbers are sufficient? Okay. So, but in that case, there's two things you can say. You can say that I'm actually, when I'm going with universal sampling, I already know that my study is not going to be powered. But remember just now I showed you an example, the one where you can actually key in your outcome measures. But in your case, you're comparing, it's actually logistics, so you might not be able to use that. But there are ways at the end to determine how powered your study is. And you can ask a statistician to kind of tell what the effect of your findings are. So yes, you can say universal sampling, it's not going to be a problem, but you still need to explain why what your finding is enough. Okay. Yeah.
okay, thank you, Prof.
Who else? Any other questions? I see. Okay, yeah. Anything else? Anybody else has a question? If not, we might end it in about 5 to 10 minutes time. No questions for me. So we can end here, I suppose. Yeah. Thank you all for joining.
Thank you, Prof.
If you all exit, then I might discuss with Nadia something, yeah, before we end the session. Thank you. Hamiza, any questions?
Thank you, Prof.
No? Hi, Philip. You have any questions, Philip?
No, Prof. Thank you.
No. All right. Thank you. You can exit. Yeah.